Thank you everybody for being here. I am Jennifer Haynes. I'm the membership chair of BHN DPG, and we have Jessica, our resource professional for eating disorders. So we're just doing office hours. Like I just mentioned, if y'all have a question and you want private, you can just shoot me a private chat through that. And then otherwise, just let us know if you have any questions. That's kind of the gist of today. But Jessica, if you want to go ahead and introduce yourself and
Yeah. Hi, everyone. My name is Jessica Steinbach. I am a dietitian in San Diego, California, and I am the eating disorder resource professional for BHN. I practiced in the field of eating disorders in all levels of care except for inpatient for about 5 years. I still do see some eating disorder patients. I primarily focus on GI nutrition now, but there's a large intersection there. And so it is something I see still on a weekly basis, which is nice. But yeah, happy to answer any questions that anybody has regarding resources or specific cases.
um, just looking to see if anybody was unmuting. One of the things that came up in our networking event, I think that was last week. I've been a mess, y'all. Was talking about that intersection between substance use and eating disorders. So I don't know if you have any other perspective to add to that.
Hmm. Yeah, that's a great question. What was the perspective that was already provided?
One of the big ones, if I remember right from the conversation, was an individual. Hold on, we have to do it a special way, so just leave it alone. Sorry. Um, where was I going with that? She worked in a psychiatric facility that was struggling to manage the eating disorder patients that they had like temporarily before they went back to treatment. And there was a lot of more discussion brought up within that realm is that they also had a substance use and they were trying to figure out this particular person had a really good what's the word? A really supportive administration that was willing to like kind of let her make protocols and stuff like that. So that's what she was kind of wondering is when she gets these eating disorder patients that come in for like a crisis care while they're at a treatment facility, like what does she need to look at for substance use versus eating disorders? And
Hmm.
I don't know if that clarified or just added more questions, but that was I wasn't sure if any of them were going to come to this session to talk about it some more, but maybe we can start that. And if anybody has questions, I saw Sharon that you unmuted. So if you have a different question, we can always go that route too.
Oops, sorry, I'm just trying to get my computer to cooperate here. Sorry about
No, you're
that.
good. You're good.
Yeah, I think that co-occurring eating disorders and substance abuse can be quite challenging to manage because oftentimes there's not like a specialty for one at a treatment center that focuses on the other. And so I think it can be really hard. I've had clients who I've worked with in the past who kind of like jump between substance use and eating disorder treatment facilities and feel like they have free range to use their eating disorder when they're in, substance use treatment facility because it's quite common. I think the biggest thing would probably be developing protocols to support with that while folks are receiving care from a substance use facility. Um, because I think it can be quite tricky. I've worked with like dietitians or staff that's present there on like ways to manage that individually. So like supported meals, similar kind of like portioning, etc., can be helpful. But I would really recommend like attending maybe a treatment facility that allows support for co-occurring. I know that there's quite a few of them, and so I feel like that's probably the best bet because you have like the dietitians who specialize in eating disorders, and then also therapists who are cross trained in eating disorders and substance abuse. So I feel like that is most ideal, but if not, then probably creating some eating disorder protocols within the substance abuse facility would be helpful.
Yeah, they definitely go back and forth for sure. I feel like
Yeah.
to what you said that I'm seeing more and more eating disorder facilities talk about substance use co-occurring.
Hmm.
Whereas like when I worked at one in the past that it was primarily substance use that did co-occurring eating disorders and it was like the only one kind of in our area anyways. And I think
Hmm.
that co-occurring treatment is getting more popular. It's important for sure.
Yeah, I agree
Uh,
completely.
Hi, this is
Heather,
Sharon. I'm sorry.
oh,
I was going to say this is Sharon O'Boyle. I actually work as a dietitian at the Caron Foundation, which is a drug and alcohol rehab. And
Okay.
that's why I decided to hop on today. I just got the invite and just to listen to you guys talk.
Yeah.
Um, just about 3 or 4 weeks ago, we had somebody we could not keep. Our goal is to keep somebody safe and able to do the drug and alcohol treatment. But when that's not possible, we do take them out to, we do send them out.
Yeah.
Yeah. The last one, they actually wouldn't take her until her electrolytes were stabilized. Um,
Yeah.
so
We
that's
ran
why I
into
hopped on
that.
today. Yeah, it's sometimes they're very sneaky and we don't catch it, and then they come back
Mhm.
and they're like, oh yeah, if they're coming back for the relapse, they're like, I puked the whole time I was there. We're like, oh okay.
Yeah,
So
that
yeah,
Sydney was on the networking call, and that's what she was talking about, the different screenings and stuff like that that could be really
yeah,
helpful, but it's you're not going to catch everybody. But yeah,
no,
we had a
No.
problem since we were primarily residential, finding somebody that would take them if like the eating disorder was, like you said, not making them safe or, things
yeah,
like that. It was hard to sometimes even get them to take our clients from there.
yes.
And yeah. Um, sorry, she's being
I
really
think I
wiggly.
saw a hand
Heather,
raised.
Heather
Heather,
raised
yeah.
her hand. Yeah. Did you want
Hi,
to?
yeah.
There you are.
Yeah, can you hear me?
Yes,
Mhm.
ma'am.
Perfect. I am using an earpiece thing. Okay, good. So hi everyone. Yeah, I'm Heather. I am a dietitian, private practice, 10-year acute care, but transitioning to private practice and very interested in eating disorder work. Went down the rabbit hole of intuitive eating, love it. And I inherited a client who is very, I would say borderline. I'm not going to use the right terms. Just she's a young kid and she's of normal size, but just really dissatisfied with body. So that's basically what we talk about. I want to support her the best I can. I don't know if she meets criteria for an eating disorder. She has a psychologist. So I was just wondering, maybe just like as a newbie to this world who kind of has a client who is, on the edge, we gently talk about it. If you can speak to that, Jessica, that would be great.
Yeah, I think that can be a tricky place to be in, and that kind of overlap between like, is it disordered eating? Is it eating disorders? Is it general just body dissatisfaction? I would say that it kind of like falls into more of the eating disorder category if there is like control or food behaviors that are intended to control body image. And so if you feel like she's actively restricting specific foods or has unsupported food beliefs and acts on them, in an attempt to control her body size, then I think it would probably be supportive to address that piece of it a little bit further. I feel like, unfortunately, a lot of young women in our society today have body image issues, and sometimes those develop into disordered eating or eating disorders, but not always. And so, approaching that lightly, not encouraging any sort of behavior change to manage body size, and really kind of just working on body neutrality or acceptance or kind of wherever that patient is at, can be really supportive. But I would say if there are pieces of her story that are coming up consistently where she's actively trying to control her food to manage her body size, then it would probably be appropriate to explore that eating disorder diagnosis a bit further. And you can always ask the psychiatrist, psychologist, I don't know what you said, to screen further for an eating disorder. That can be helpful. I don't know that those screening protocols are always the most effective, but at least it's a good starting point.
I wonder if you could expand, I don't know if expand's the right word, but if you could speak to like maybe some of the alterations in language to avoid triggering eating disorder thoughts, since a couple of them at least mentioned being kind of newbies in that area.
Are you referring to like when discussing food specifically?
Hmm.
Mm-hmm.
Yeah. Or I mean body
So
image too, I think, but
yeah, I would say avoiding this idea that like one size of body is better than the others, or encouraging intentional weight loss, or even kind of entertaining that idea, especially if there's concern of a potential eating disorder. Saying like, yeah, you could absolutely, limit your fries and have a fruit on the side, and that would be supportive with weight loss. I think we want to be really careful about providing any ideas there. And like I said, trying not to engage with those desires to control body size in these situations, avoiding discussing foods as like good or bad or healthy or unhealthy choices can be really supportive for reducing any sort of judgment around specific foods that tends to really perpetuate eating disorders. Um, I think encouraging like regular meal times. I know people worry about should I be snacking? Should I be eating past a certain amount of time? So, kind of speaking to that intuitive eating piece of everything, but just really focusing on nourishing appropriately and according to hunger cues versus feeling like they have to only have specific portions or only eat at specific times. I think that can be really supportive. I don't always recommend intuitive eating if there is restriction because those two things don't always go hand in hand. So, if there's concern for active restriction, typically we try to support with nourishing appropriately and kind of decreasing those beliefs that there should be restriction. And then we can move over to intuitive eating once they're more stable with their intake.
One thing I've noticed, and I just I don't know if you have any insight into it, if I'm working with somebody with co-occurring like substance use and eating disorders, those individuals seem to describe their eating disorder as an addiction versus people without addiction don't describe their eating
Yes.
disorder that way. And like I said, that's a very anecdotal general, but I don't know if there's thoughts behind that.
Yeah, I hear that often come up with like sugar, and I think that
Mhm.
probably comes a lot from media discussions around how sugar is addictive. And we know through the research that it's not actually addictive. It triggers like the same neural pathways, but that's mostly because we are like feeding ourselves, right? Obviously, there's pleasure that comes along with that. And we want to be feeding ourselves evolutionarily. So obviously, there has to be some sort of benefit from for that from like a neurological perspective. And so trying to dispel those ideas that food is not addicting in nature, that sugar is not addicting in nature. Oftentimes we see this more like feeling of out of control or like addictive response to these foods when we've been restricting them heavily or have thoughts about not being able to eat them. So there tends to be kind of this like pendulum shift, or I think it's in the intuitive eating book, but they call it the Last Supper mentality, where it's like, if I'm never going to have this food again, I might as well go all out now. And so that desire to, or that actual engagement and restriction oftentimes can result in eating past fullness, especially with specific foods. And then I think that registers to somebody as addictive or that they have an addiction to something. So I think trying to dispel that you can't be addicted to food gently can be helpful, but also not invalidating their concerns. I think it takes a lot of like gentle education.
When, like when you're talking about substance use withdrawal in particular, alcohol and opioids in particular, but all of them can really cause sugar cravings. So now you're battling withdrawal sugar cravings on top of, any kind of eating disorder voice that's getting louder in the withdrawal period.
Hmm.
No. Sorry, hold on. I'm gonna mute. Sorry, she just had a birthday and got makeup and she's trying to go on my table. Do y'all have any other and feel free to change the subject if you have another conversation. It doesn't have to sit around substance use at all. And just make sure this is helpful for everybody. So if y'all have something else to ask within that or switch gears.
Hi. Um,
Hey.
Hi, my name's Leanne. I work in the behavior health center inpatient setting for like almost a year. And then well, so I'm just quite interested about curious about what you say like when to use intuitive eating. So so I thought it would be like universal, but it seems like it's actually better not to. Could you like explain more like in what situation that we can use the intuitive eating
Yeah.
and work not? Thank
Yeah, absolutely. I
you.
think the main area, especially in the eating disorder field where intuitive eating is not appropriate, is if there's active restriction, or beliefs, desires to restrict, because it gives that part of the eating disorder permission to not finish something when sometimes people like need to be finishing something as far as like a medical safety standpoint, or they're hungry still and they're convincing themselves that they're not hungry. So this whole idea of intuitive eating is essentially like being able to connect with body cues around hunger and fullness. And if somebody is not able to do that effectively because they're struggling with active restriction, then it would not be appropriate. So for example, when I worked at a treatment facility, we would like bring in takeout food as a food exposure. And I had one client who we were kind of exploring the idea of intuitive eating. She was doing a great job of continuing to complete 100% of her meals and snacks, which is often expected at that level of care. And so when they're actively doing that consistently, they're not really showing a lot of urges or desires to restrict, then we can kind of explore intuitive eating a little bit further and see if it's appropriate or if the eating disorder latches onto that and is like, ooh, yay, permission to restrict, right? And so we had Taco Bell, and I'm sure we all know Taco Bell burritos are quite small. And she took one bite of it and was like, I'm full. Like my hunger and fullness cues are telling me I'm full and I don't need to eat any more of it. And obviously, we know that that's not an appropriate serving of food for lunch. And so that would be a time where intuitive eating would not be appropriate because when given the opportunity, those restriction urges and behaviors came back quite strong. And so really just exploring that. And it's not always like as cut and dry as that. Sometimes we need to allow opportunity to explore intuitive eating and have really open conversations around what that internal dialogue is to better determine if somebody is ready to engage with that.
Jessica, I think it was one of your office hours that you were talking about kind of the brain fouling. So it's almost like you have to get the mechanics down, right? Like eating enough
Mm-hmm.
before the brain has the ability to process those things. I don't know if you have more to add to that or if that was enough, but
Yeah.
you got to get that piece taken care of, right? Before the brain can fully process and learn the more intuitive abstract things, right?
Yeah, absolutely. Yeah, a malnourished brain isn't always able to think very clearly, and so we see an uptick in OCD behaviors and anxiety, right, in those situations, and the inability to really like logically think through experiences. So typically, we need to get that person to like a well-nourished state. When I was working in treatment facilities, we would really work on the basis of body weight. So if they were like 100% of their body weight or within 10% or so, or kind of stabilized, then that might be appropriate to kind of explore intuitive eating a little bit further. But if somebody is still weight restoring, we wouldn't necessarily want to explore that, both from that neurological perspective, but also if someone's eating less, then it could complicate their weight restoration. That's not always as significant at the outpatient level of care, especially if somebody has gone through all the steps of treatment. I think outpatient, we oftentimes work a lot more on intuitive eating because they've progressed through inpatient, if necessary, residential PHP, IOP, right? And they've really worked on nourishing themselves appropriately. In most cases, some have not. And then I think outpatient is an appropriate time to really start intuitive eating, and sometimes PHP, IOP, just kind of depending on the client.
Just also one more question.
Mhm.
If I want to like explore more on eating disorders training, so what kind of training would you recommend? Or like I found there's some like counseling master degrees, and there's also a certificate that that require intensive training. And so like which route, or do you have any other routes that you recommend?
Yeah,
Mm,
IADEP offers a
mm.
certificate for dietitians or like a specialist. I don't know what the acronym is for it. I can't remember. Certified eating disorder specialist dietitian, I think. So that's an option. I think like just doing trainings generally can be really supportive. So there's like EDRD Pro. They have a ton of fantastic trainings. It does cost money. I believe it was $19 a month. I don't know if it still is. But they do offer a lot of like previous resources and additional like upcoming trainings that might be supportive. I think supervision with an eating disorder dietitian can be really, really helpful because you can learn about specific cases and ask questions. Books, like just reading, I think like Sick Enough is a good book. Jessica Setnick has quite a few options as far as like books go for eating disorders. But I think just like exploring the topics a little bit more from like a training perspective, and then also maybe like shadowing appointments or doing supervision can be really helpful. Training is fantastic, but I think practice is really where you become a really good dietitian just generally. And so prior to working in a treatment facility, I had a lot of the education around how to handle situations, but that definitely did not come as in handy as I was hoping to. And I was face to face with clients who were really struggling. So I think practice really, really, really helps. And so if you can do that in like a controlled setting, maybe it's like a group supervision or one-on-one, that can be a great way to practice those counseling skills.
I think there's a lot of fear about interacting with the clients, and the only way to do that is to do it, unfortunately, right? Yeah.
Yep.
Yeah. So, but well, I did like face because it's inpatient and many there are like all kinds of disorders, the mental disorders. So some like everyone is different when their background, like medical background, and that the toughest. There are two most toughest patients. One is the 13-year-old boy who lost father maybe a year ago, 7 or 8 months ago, and then he has a twin brother, but they are identical. No, they are not identical twins, but one of them handled the grief well and adapt. The other one just couldn't, like the grief was like last longer, become chronic, and he just refused to eat, and it was so tough. He refused to talk. After half hour of talking, I only could persuade him to drink the water, and then he just wanted to suicide. And later he went to the acute inpatient setting because he just was so like medical situation was so dangerous. And they put IV on him and he will pull them out. And like eventually he was forced to eat, and I think tube feeding was used. And then after he was medically stable, then he moved back to the behavior center. I don't know where he eventually went, but it seems like our doctors, we all were not able to handle him. Just no way to always just tell him to go away. He doesn't want to talk. He doesn't, and he's still trying, like hide a pencil to try to use as a tool to hurt himself. So like in this situation, I don't know. I just feel so sad, and I don't know what really I can do for him.
Yeah. Yeah, it's really hard when there's co-occurring mental health because there's not a lot that we can do as dietitians, unfortunately. I mean, we can do our best to support with nourishment, but a lot of the times it does require intervention. And there are a lot of like inpatient eating disorder facilities, like Acute in Denver is a good option for like weight restoration. But I think that a lot of the time there just needs to be very, very, very strong team dynamic there where you have the therapist and the psychiatrist and the physician and the dietitian, everybody really working to address those patients as extensively as possible because none of us can just do it on our own.
Yeah, exactly. Yeah. And the other situation was not, the medical situation was not that bad, but he was like bisexual, and he think he's a girl and he wants to be those tiny gay boy, so, but he's tall like by nature, so he just tried to not eat and then starve himself until he came into the inpatient setting. I think he ate because he wanted to go out. He wanted to be discharged, but the attitude is like you can tell. It's so hard to like he would just ask information for like vegetarian diet. So I try to offer him all those information why you need to eat, and then but he seems like being very offensive and like guarded. The only motivation is like if I can go out, if the only thing I can go out is that I eat, then I'll eat. But it's like I don't know what he would do after he's discharged.
Yeah,
Yeah.
I would say typically in those situations, it would be
Mm,
appropriate to
mm,
refer to a lower level of care. So if that's
mm,
inpatient, maybe
mm,
refer to like a residential treatment for eating
mm,
disorders.
mm,
Is probably going to be the most supportive because it sounds like
mm,
they need a lot of
mm.
care around managing the eating disorder.
Yeah. So I did talk to the mother to refer her to a dietitian, but it seems like she has like 8 kids,
Mm.
and then it's like, and she's overwhelmed by all the kids, and like the reason that kid was had mental issues and got anxiety and eventually come into the inpatient because the mother went um went on vacation for a month without the kids, and the kids have to like take care of themselves. So, and I really doubt the mother will find a dietitian for him.
Yeah,
Yeah, that's
yeah.
it's
Those are
just
hard cases. I mean, the best
mm-hmm,
we can do is refer and give our
uh-huh,
recommendations, but we can't
mm-hmm,
always guarantee that they're going to
mm-hmm.
act on that.
Okay, I see.
Curious
Yeah.
about how everybody feels the line
Mm-hmm,
is on being a mandated reporter in that case. Like, I know I don't know how old,
mm-hmm.
I missed how old your
Oh,
patient was there, but
they're 13. I think both of them are
13.
13. Yeah. Yeah, 13 is a very tricky age. A lot of the pediatric patients are 13.
Yeah.
Yeah. Mm-hmm.
I'm just curious if that would
Well, yeah.
almost warrant
Mm.
reporting to CPS in that case too, or considering
CPS.
it.
Okay. Mm. Okay, that's a good point.
Because a
Yeah,
month,
Mm.
I mean,
I would assume
Mm.
that there's like a therapist and that's
a
in your
Mm.
setting, right?
caseworker.
Or a
Yeah.
caseworker and everybody
Yeah.
is aware of the
Mm-hmm.
situation.
Yeah. Mm-hmm.
Yeah.
Yeah. Mm-hmm. I see. Mm-hmm. Thank you.
There is the Academy has at least 2 webinars that I can think of specifically on transgender care. Marissa, she was our IDEA liaison. They did an event, I guess, fairly recently where they had a really good talk on it as well. And a lot of it's supporting and, that kind of thing. But if that feels really uncomfortable, there's a little bit there. There's probably also a ton of other resources. As far as nutrition goes, the Academy does have a couple of webinars on that as well.
Hi, Jessica, Heather again. And
Hey.
sorry, I have a toddler back there.
Oh, I do too.
Yeah, she's doing her thing. In terms of chronic dieting, and I know I'm coming at this and there's a lot of parts of behavioral health, but I'm just stuck in this little world here. Chronic dieters or like people even in your life, like who just continuously diet. Maybe you could speak a little bit about, is that considered an eating disorder? I mean, in my brain, that's a very uncomfortable way to live. So maybe how to manage them. So I'm not in the higher level of care. I'm just kind of, in the outpatient setting. So that's sort of who I'm seeing, but they still want to diet. And we're just having these kind of annoying conversations where I'm like, I don't know if this is helpful for you. So maybe in that lane with chronic dieting, kind of eating disorder, if you could speak a little bit to that, that would be helpful.
Yeah, I mean, I think it could develop into an eating disorder for sure. I feel like at that point, it probably falls a little bit more into like a disordered eating category versus an actual eating disorder. Oh, it looks like Jennifer just put in a paper. Oh, like an info page on that piece of it.
It's the National Eating Disorder, the Australian one popped up, but it talks about some of the differences. I mean,
Difference
listen to
between.
Jessica, but if you like to read, then that'll be there too.
Thank you.
Yeah. And so I think that kind of determining like the level, I don't want to use the word severity, but like how much of like a space it's holding in their lives if they're all consumed with it. There's zero desire to like engage with recommendations. It probably, I would say, would fall more into that eating disorder piece of things, versus disordered eating. It's hard. I think eating disorders, disordered eating is hard, period, because we as providers are intended to reduce harm and manage care as best as we possibly can, but we can never force anybody to stop doing something, even if we don't agree with it. And so I think it really depends on how you want to practice as a provider. I know that there's some providers that set really clear boundaries of like, if you're not going to listen to me, I'm worried about your care, your safety and your health. And at this point, like I don't feel comfortable working with you any longer. And so they'll discontinue care. Other providers are willing to work with folks, from like a harm reduction standpoint. So understanding that they're going to engage with these behaviors regardless of if they see them or not. So how can I try to like reduce their harm as much as possible and discuss with them like the most appropriate interventions that are possible. I don't know that chronic dieting is necessarily an eating disorder per se, but I think, like I said, it can develop into that. So providing education around why we wouldn't want to do that, the dangers of yo-yo dieting, of weight cycling, and then allowing them to determine how they want to proceed from there. But that doesn't mean that you need to engage with supporting them with their diet. I think it's our job in this space of eating disorder professionals to provide a lot of education and support people with breaking that cycle. Um, so say they come to you and they're like, I want to lose weight, and your boundary is I don't do weight loss counseling, which a lot of outpatient like eating disorder, disordered eating providers do. And they're like, okay, well, I'm willing to, do what you want to do. We can kind of talk about what it would look like for me to not diet. Then I think it's fantastic to work with them and try to provide education. But if they want to be doing like dieting and weight loss and you don't feel comfortable with that, I think it's always appropriate to refer out to somebody else if you don't feel comfortable, because there's plenty of weight loss dietitians out there.
Did that bring any other questions up for you, Heather?
Oh, sorry, guys. I'm having speaker issues and toddler issues, but thank you. I'm just going to listen from here on out, but thank you. I appreciate the insight.
Of course.
We have a couple that have been quiet, and that's totally fine. Not pressure to ask questions, but I just wanted to make sure you are getting what you wanted out of coming to office hours if you have any other questions.
I could ask a question. Hi, I'm Meryl. I'm a grad student and I'm currently in a rotation with Jennifer. And thank you for having me. I was just speaking with a fellow student in my cohort who she's on the track for exercise physiology, and she was talking to me a bit about patients who have orthorexia and how sometimes it can be harder to identify certain like patterns with eating disorders as far as um, athletes in particular. And I guess I don't know if I have like a specific question, but I'd love to hear a little bit like about kind of things to look out for where there's no signs per se of malnourishment or undereating, but you start to put the pieces together that there may be certain patterns as it pertains to orthorexia or other disordered eating with athletes.
Yeah, I feel like the athlete population is is challenging because there's a lot of focus on how like specific ways of eating and depending on the sport, specific body size can support with improvement in performance with their sport. And so I think that trying to distinguish like what's necessary and what's not, and often it's outside of the athlete's control. Unfortunately, it comes a lot from the pressure from coaches and whatever, right? Who might be expecting some specific body size, and so they don't feel like they have a choice. And oftentimes they don't. I think if you're comfortable, like providing education to coaches can be really supportive. But if you feel like it's coming directly from the patient, I would say orthorexia goes beyond just like concern of your health, but more of like an obsession and a rigidity with things being healthy. And oftentimes, orthorexia spans outside of just food. So it would go towards like cleaning products and skincare, right? Where you want everything to be as little ingredient as possible. And so we see that it doesn't just affect their relationship with food, but it's like this obsession with like ingredients and cleanliness that rules their life. And so I think when we look at like how much of this does it become consuming with something can be really supportive. And also their like willingness to break those cycles. I feel like when I was working with athletes and there was concern with potential for like eating disorders or disordered eating, explaining to them like you not getting enough food and not having a menstrual cycle is significantly going to impact your bone health. And if it impacts your bone health, that can impact your performance. And if they still were like, I don't care, I'm not going to change, I don't want to gain weight, that's a red flag, right? And so if there's no willingness to support their health and their performance, then I would say that that really does fall into the territory of like an eating disorder or disordered eating. Because if their desire to maintain a specific body is to improve their performance and what they're doing is putting them at risk to not improve their performance, then it's not actually about their performance, it's about something else. And so I think really being able to determine the why behind the behaviors can be very supportive.
Thank you. That's super interesting because I hadn't really thought about it like in the just kind of what you were saying about how they can also become obsessed with like least amount of chemicals and things because I also had talked to this person a little bit about how like the obsession with like is this ultra processed like which now especially like we're all obsessed with like talking about ultra processed foods but like
Mhm.
I hadn't really made that connection with people who could potentially be dealing with orthorexia and how that like becomes a separate obsession. Is that something that you really see more in those patients and not as much in like other disordered eating?
Yes, I would say that when it becomes obsessive or like all consuming, then it becomes a problem. Because obviously it's okay for us to be like, no, I would prefer for that not to be an issue. But if you feel like you can't move past it because it's an issue, it's so overwhelming, it causes anxiety, it causes depression, it causes overwhelm because of, I don't know, a specific ingredient, then I would say that that is like obviously more of where the problem comes from, because I think it doesn't allow for flexibility, which we know we have to be flexible, right? Like, what if you're on a road trip and there's nothing that you can eat that fits in that criteria, so you choose to not eat anything? Like, that's a problem when you're not willing to eat anything because it doesn't fit into like this very clear criteria of what's like safe and clean to eat. That's where that concern starts to come up.
Yeah,
That's really
Mario.
interesting.
And so you also have to consider that we kind of live in a society that normalizes some disordered and orthorexic behavior,
Absolutely.
right? And so when
Mhm.
somebody is like really into that, they may not recognize that that's not like a normal reaction to whatever piece of information that they saw. Somebody else wouldn't react that same way, So it's really hard to tease some of that out.
Yeah. Thank you.
Absolutely.
Sweet girl.
Any other questions for me or for Jennifer? also going to put my email address in the chat just in case anything comes up. If anybody has any other questions or maybe wasn't comfortable asking a question on here today, which is totally understandable. I get like that too. Feel free to email me at any time, and I'm happy to offer additional resources or support.
Yeah, so outside of office hours, the discussion board is great for stuff like this. And the resource professionals generally try to kind of see if there's any discussion that they can add some expertise or resources to or anything like that. Yeah, I don't think I have a whole lot to add. These are good questions.
Yeah, this was fantastic. Thank you all for being so engaged.
Yeah, I don't want to cut anybody off, so somebody's thinking about asking a question, but we don't have to sit and stare at each other either, right?
Thank you.
Thank you.
Thank you.
Thank you.
You're very welcome. Thanks everybody for being here.
Doesn't have the earbuds on, baby. She's mad she can't hear y'all. Okay, did Meryl jump off? I was just gonna ask her if she had anything else before she jumped off, but that's all right. All right, awesome. Thank you, Jessica.
You're welcome. Thank you. I'll talk to you soon.
Bye. Bye, Leanne.
Bye.